We have our next speaker. And by the way, I had the opportunity last night to go out with these speakers. They are a lot of fun. We had a really good time last night. My jaws, my smiles, everything, my whole face was sore from laughing so much. It was a lot of fun. So it's a pleasure to be here with these speakers. So our last speaker of the day is Michelle Alfa. She is a professor at the Department of Medical Microbiology at the University of Manitoba. In addition, she is a principal investigator at the St. Boniface Research Centre, where she is part of the CCARM research group. She has worked for the past 25 years as a PhD certified clinical microbiologist involved with diagnostic microbiology, teaching, and research in the area of hospital-acquired infections. One area of her research is C. difficile and the role of spores in the environment as a means of nosocomial infection transmission. Her studies have investigated how to ensure optimal environmental cleaning as well as ways to audit and ensure housekeeping compliance in healthcare facilities. Dr. Alfa has received the Distinguished Microbiologist Award from the Canadian College of Microbiologists, the Doctors of Manitoba Award for Administrative Policy, as well as the Research Innovation Award from the University of Manitoba. Please welcome Dr. Alfa.
Thanks for that introduction. I like the beginning of it even more, that we're a fun group to be with. You know, a few glasses of wine and it gets even better. I couldn't even speak French when I imbibe on wine. I would like to thank Nicole in particular, but Virox and IPAC for actually inviting me to come here and share with you what is my passion in terms of hospital-acquired infections through improperly reprocessed medical devices. So thank you for that opportunity. And I need to share a little anecdote with you, because when Nicole told me what my topic was, hot topics, do whatever you want, Michelle, just give us some information that's useful and valuable. And I couldn't help but laugh, because when I was about, 16 years old in high school, I grew up in a rural farm in Manitoba, a very poor farming family, and my mother relates this story to me. She said, Michelle, I knew you were going to go into science, because she said, every day you come home from school, you would zap off the bus into the house, and my mom would be there, and I'd say, Mom, did you know? And then I would proceed to relate to her all the details of, eukaryotic cell replication. There's meiosis and mitosis, and oh my gosh, and I'd go on and on and on and on. And I think she kind of got probably a little tired of this. And so one day I zapped off the bus and came in, and my mom looked at me and she said, before I could get a word out of my mouth about what I'd learned in school that day, she said, Michelle, do you know what halitosis is? And of course, at 15, 16, I was stumped. I had no clue what that was. And of course, it's bad breath, right? And I had to go look it up in the dictionary. And it wasn't until years later my mom shared with me that she had scanned the dictionary for hours looking for just the right word that she could use that I wouldn't know. So I'm really very much excited and into kind of hot topics and kind of what's new and interesting. And so thanks very much for the opportunity to share what I think is nice and interesting with the rest of the group. So what I'm going to do is, we'll see if I can get this. I've listed a series of disclosures here. It's primarily to indicate that the research lab I have at St. Boniface Research Centre, we've actually done a lot of studies for a lot of different companies. I've been involved as an expert on panels for a lot of different companies, but I'll be frank, I'm an independent research laboratory, and my objectives really are to share with you what is scientifically in the literature, and my whole goal is really to share information so that people can be aware of things that are going on. So that's my objective for today, is also to try and make sure that in terms of hot topics, I provide some information that is of relevance to the group. So what are the current issues affecting infection prevention and control, and kind of what's in it for me? What do I need to know? I love this picture that I found off of Google Pictures, because it just makes me think of the real scary bugs that are actually out there. And what I'm going to do today is there's a couple of areas that I'd like to touch on. So initially, I'd like to go over medical device reprocessing. What are the current problems in terms of infection transmission? And Susie has helped me out because she reviewed one of the ones that I'm actually going to talk about as well. But I do have an aspect of that that I would like to share a bit more information on, in particular the biofilm issues, and we touched on that kind of in the questions. And then I'd like to touch a bit on environmental services in terms of disinfection and monitoring compliance, because I think there's a few new issues in that area. And we've been talking with colleagues here how environmental services are really becoming at the forefront in terms of issues related to containing hospital-acquired infections. And then finally, I wanted to touch on a few things in the CSA guideline, and really just to show you some of the approaches that are being taken in this new guideline. It's a great document, and if you don't have it, I would really highly recommend that you get it, because it's actually got some very significant changes that I think are definitely for the better. So let's start off with biofilm and medical devices. This is hot chili item number 1. ERCP and duodenoscopes and other GI flexible scopes, I'd like to touch on those. And then the arthroscopic cannula and handpiece issue that Susie had described initially, I'd like to spend a bit of time talking about that one as well. And the objective in this is we don't do a good job of sharing information across Canada, much less around the world, in terms of understanding how we can do things differently to reduce hospital-acquired infections. So I'm hoping that by sharing and discussing what I think are the germane issues in these reports, that we'll actually all end up having better processes at home. So infection transmission from contaminated flexible endoscopes, there have actually been a number of reports that have been published. 2010 in France, there were actually 2 reports that came out regarding ESBL and carbapenem-resistant strains of Klebsiella pneumonia. And in the United States, 2013 was the first time that there was a report by Alfa et al. About carbapenem-resistant Klebsiella pneumonia in ERCP scopes. And the one that I would like to focus on for today's session is a very, very recent MMWR report about New Delhi metallobeta-lactamase, or the NDM strain of E. coli. And I think you're going to see a trend here. Years ago, I predicted that this type of trend would happen, and there, some people just think you're a fanatic and you think nasty things are going to happen, but I do think that this is an up-and-coming issue that we're all going to have to face in the not-too-distant future. Okay, NDM E. coli. What does this mean to me? And it's interesting to me when you look at the incidence of NDM strains or the appearance of them in the United States. So in 2009 was the first American isolate reported for NDM E. coli. And over the intervening years between 2009 and 2012, there were actually only 27 US cases, so extremely rare. And then what happened, which was really very interesting, from January to September in 2012, there were 69 cases, 44 of them from northeastern Illinois. And of course, that stimulated, because an NDM strain of E. coli is a scary event because of the resistance of that organism and the ease with which it tends to transfer and colonize, and the increased morbidity and mortality rates associated with it. So of course, this stimulated, the first few cases stimulated an outbreak evaluation or investigation. And what was interesting was that in northeastern Illinois, the first 9 cases that they reviewed were actually linked to ERCP procedures in one specific hospital, and the odds ratio of you getting this organism from that hospital was 78-1, increased if you went and had your ERCP done in that hospital versus any other site. What was scariest to me, though, and this was kind of the point that Susie was making as well, they did an investigation, and what they found was that 1 in almost every 2 patients that those scopes were used on actually acquired and became carriers of an NDM strain of E. coli. 46% transmission rate. That's 1 in every 2 patients. That is scary. And it's been one of my pet peeves that for years the public and ourselves as healthcare professionals tend to focus on the bloodborne pathogens, and we forget about the fact that the bacterial transmission rates are far higher. And the ERCP elevator channel, the actual lever component of it and the channel, grew the NDM strain of E. coli and carbapenemase-resistant Klebsiella pneumonia. It had two very nasty organisms in it. Now, what I'd like to talk about is NDM strains of E. coli are, in my opinion, very frightening. And the reason I say this is, as a microbiologist, I can tell you that from the laboratory reports, the one organism that causes the most infections in humans, whether it's bloodstream, pneumonia, UTIs, etc., is E. coli. E. coli has the pathogenic characteristics to actually cause very severe and invasive infections. And if that strain is also multi-antibiotic resistant, that's a double whammy that we don't really want to contend with, and we certainly don't want to see it being spread from patient to patient. So interestingly enough, when they investigated the site that actually those ERCP procedures were carried out at, they did assess the cleaning and the disinfection, and they said that based on their review of the written protocols and also observational studies, they couldn't find apparent breaks in reprocessing. Now, I find that hard to believe, because I do believe that with flexible endoscopes, it's the multiple little forgetting of steps that accumulate, and it's not the new endoscopes that cause the problem, it's the ones that have been reprocessed multiple times that we end up having difficulties with. So even though in the report it did indicate they could see no breaks in reprocessing, I wouldn't be surprised that there were a few transgressions that actually did occur. So the NDM strain is multi-antibiotic resistant. It does cause E. coli, even more so than Klebsiella pneumonia, can cause a range of infections that, the sky's the limit. It's not like a VRE. If you get acquisition of VRE, 99% of the time, it's not causing an infection, it's actually carriage, and we're trying to prevent the transmission of that. But when you have a bug like E. coli that gets into the system and those patients become colonized with it, and it doesn't cause an infection initially, because transmission doesn't mean you're going to get sick with it, but if they end up going maybe a week, 2 weeks, a month later, and they still have that strain in their GI tract, and they get treated with antibiotics for another reason, guess what the last bug standing is going to be in their GI tract? It's going to be the multi-drug resistant E. coli, the NDM strain. And Pratish Tosh actually published an article recently, and it was entitled Tending the Human Microbiome. The idea that if we get colonization in our GI tract of some of these multi-drug resistant organisms, that transmission might not immediately cause an infection, but as we disturb the microbiome by treating with antibiotics, what do we have? We end up getting the majority of your GI organisms being multi-drug resistant ones that then can go on when you're in a more compromised situation to cause serious life-threatening infections. And the treatment options are very limited. For both Klebsiella pneumonia and E. coli, you've got limited choices in terms of antimicrobics that can be used or combinations that can be used because these bugs are so resistant to many, many classes of antibiotics. And the other thing about it, which is not totally fully understood, they do have high transmission rates and high infection and mortality rates. So these E. coli strains that are NDM strains are obviously very robust and very able to compete with our normal GI flora and find a home in our GI tracts. So my take-home message on this one is be prepared. It will show up at a hospital near you. You can see in the US there was virtually no strains before, or no identified strains before 2009. 2012 they basically have had a rapid increase in them, and I believe that in Canada it's just a matter of time before they show up. Right now they're extremely rare in Canada. But one thing I'd like to raise your awareness about is that if you do see a strain like that showing up, and you are doing an infection prevention and control workup of it, consider the linkage with the GI endoscopy, because that's where the outbreaks in the US and certainly the ones in Europe and France have actually derived from. And the thing that gets me is biofilm development in flexible endoscopes, I believe, is the root of all evil in terms of organisms surviving in flexible endoscopes. And I've had discussions with gastroenterologists who look at me and say, you know what? We do fecal transplants, sometimes using an endoscope to actually instill it into the lower GI tract. What's your big whoop about a few organisms being present in the flexible endoscope? And to me, it's, for those of you who remember, it's like Walkerton in Ontario all over again. A few E. coli in the drinking water is no big deal, but if those few E. coli happen to be E. coli 0157H7, that's a whole nother ballpark. And people died because of the things that happened in Walkerton. And I believe that with flexible endoscopes, I think we need to be careful that I wouldn't mind betting transmission of gram-negative Enterobacteriaceae probably has happened fairly frequently and happens on an ongoing basis in clinics that do endoscopy. And the one factor that I think contributes to that the most is storage of scopes where there's moisture in the channel, because I believe that the adequacy of drying is not that great for most of our endoscopy clinics, and that's where buildup biofilm actually starts forming. And I think that we are going to see it reach its hiatus because of transmission of multi-drug resistant organisms. So, you know, a few E. coli between friends is not a big deal, but if that E. coli is an NDM strain, that's a totally different ballpark. So be prepared. Okay, Susie talked about the arthroscopic shavers, and that's great because I can spend less time on going over things. But what I wanted to focus on was the fact that in this report, they did a thorough investigative process as well. And although there was residual tissue that was actually shown within the channels of both the trocar that's used for introduction of the handpiece and the handpiece itself, the authors there felt that there must have been some type of biofilm buildup. So a piece of tissue that stays inside a cannula, probably when it goes through steam sterilization, it's going to probably be totally eradicated of viable organisms the first time it goes through. But as it is undergoing steam sterilization, it's essentially going to stick that piece of tissue onto the stainless steel inner channel, and that tissue obviously is then going to become part of the inner channel as reprocessing is done. Now, in this investigation, they feel that the Pseudomonas strain that was part of this probably derived from water sources in their sink, because they found exactly the same strain in their sinks and faucets within the facility. They found the same strain in the suction canister. They were not able to get anything out of the actual handpiece or cannula to show that that same Pseudomonas was in it, but they speculated that they feel there was biofilm buildup on that residual piece of tissue that probably protected it, because we're talking steam sterilization. You know, the idea that you have failure, and there's this preconceived concept that if it's steam sterilized, you know, you've got total sterility of whatever's coming out of it. And it just goes to show that if you have retained tissue inside a cannula, as it gets reused, if that tissue stays there, it likely will become colonized with microorganisms that are most likely water-derived, but could be from any source. And so the handpiece suction lumen, they deemed, had been properly reprocessed, whereas the trocar, they did indicate that there had been a few breaches in the reprocessing of it. But it was interesting to me because based on this incident, the FDA actually issued an alert. I don't know if you're aware of it or not, but there was an alert that came out in conjunction with this that said to endoscopy clinics, you should be inspecting the inside of your arthroscopic shaver handpieces using fiber optic small narrow devices that allowed them to see the inside. And I would bet my bottom dollar that out of all the people in this facility, at not one of your facilities you've probably actually implemented using fiber optics into the handpieces. I know at our facility that isn't something that is being done. But it's the concern of the FDA that it's really the retained tissue that is the basis for that biofilm buildup and the inability of steam sterilization to actually kill organisms that are inside the tissue. So the key conclusions were that there was inadequate cleaning. Tissue remained in the lumen of the handpiece despite cleaning and steam sterilization, and they were following the manufacturer's instructions for the handpiece. So one of the things that FDA is on the warpath about, and that's my opinion, of course they don't say they're on the warpath about anything, but they are really looking at the validation that's being done by manufacturers, because if you're following the manufacturer's instructions for use and you still have residual pieces of tissue in your handpiece, what gives, because that shouldn't happen if they truly validated their method with the right test materials. So they're looking at trying to ensure that the test soils that are used for validating the medical device are appropriate for what that medical device is being used for. So for instance, orthopedic surgery, bone meal or bone fragments, for arthroscopic pieces like this, where tissue is obviously going up that suction channel, they want to make sure that the manufacturers are validating their equipment using appropriate test soils. Now, the autoclaving was not adequate, and that was obvious from the transmission of the same strain occurring. And the transmission rate was 1 in every 10, and that's an extremely high rate for a medical device for transmission of a bacterium after steam sterilization. So again, you can see with both of these examples, the transmission rates are actually very, very high when they have outbreaks. And I just wanted to make you aware of the FDA safety alert that was issued in the United States. Obviously, Canada doesn't necessarily does not come under the jurisdiction of FDA, but we tend to be aware of anything the FDA says you need to look at. We tend to adopt it in Canada as well. Okay, so that was my first, hot chili pepper kind of set of items, and really related to raising awareness about biofilm and build-up biofilm in flexible endoscopes causing infection transmission. And when it does, and it's a multi-drug resistant one, we need to sit up and pay attention. And the other one that I talked about was the arthroscopic shavers, and the idea even steam sterilization can fail if you overpower it. The one I want to turn to now is really environmental services and the issues around that. And I was really, proud of Louise and Michelle's presentation this morning, because those two ladies did a lot of work actually in terms of standardizing the environmental cleaning and have done a great job in developing a good training package. So I wanted to mention, we're all aware of the PIDAC document, the 2009, that was revised in 2012, and that based on recognition, and Sid Sattar talked about this earlier, if you're using a cleaning agent that really doesn't have much killing ability, you certainly can spread organisms around in the environment, and if they're antibiotic resistant ones like MRSA and VRE, we really don't want that to happen. And based on that, both the CDC and the Canadian guidelines are now recommending it's not just cleaning, because years ago it used to be just the physical action, right? You do a good job of your physical action, you're good to go. It doesn't matter what agent you're using to do your cleaning with. And it's now recognized that you really need a disinfectant in addition to cleaning to ensure that if you have a few residual organisms on the surface, you're able to kill them. And so that there will be basically an overall reduction of those organisms in the healthcare environment. And that high-touch surfaces, and you need to look at cleaning compliance monitoring. So these are three things in the PIDAC document, even though it's not, it's 2012, okay, it's a few years old, but the reality is, I think these issues are ones that we all need to be spending a little bit of time and assessing how we're going to ensure cleaning compliance. One of the points that was touched on, and it was touched on by, I think, a couple of people in today's session, is privacy curtains. They are absolutely a high-touch area. They are not part of the high-touch list in the PIDAC document, and I think they've kind of been under the radar for a number of years. Oftentimes, the healthcare givers will actually do their hand hygiene, put their gloves on, go into where the patient bed is, and then pull the privacy curtain. And so the issues around that, I think, are ones, there's been some very recent publications that I think are valuable for all of us to be aware of. And the fact that up until this point in many healthcare facilities, it hasn't been part of the routine patient care cleaning. It's been part of discharge cleaning, where if there's, the curtains are taken and sent for laundering. But otherwise, on a day-to-day basis, unless they're visibly soiled, they don't get anything done to them. And I wanted to share with you this is a study that was done in 2012, and it's Ohl et al. And what they looked at, and this is an American study, they were looking at the rates of detection of MRSA and VRE on privacy curtains. And I'll draw your attention to the MRSA rates here, that on individual curtains, 6.2% of them carried MRSA, and for VRE, 13.8% of them carried VRE in this particular center where they did the evaluation. Now, that's obviously hospital specific. I look at that and I think, oh gosh, that just grosses me out to think that they would have that higher rate of the presence of these organisms on their privacy curtains. We've actually done culturing in our facility as well, and it's, we can find organisms there, but the rates of VRE and MRSA are much, much lower than these ones. So keep in mind, this is an example of a hospital in the US, but the reality is, unless you look or culture, you really don't know what your own rates are. But the point here is that when they put up new curtains, it was a very interesting study because, number one, they identified that these antibiotic-resistant strains can reside on privacy curtains, so we should be doing something about them because they are high-touch areas. And they also talked about the fact that once they put new curtains up, they very rapidly become contaminated. And that's similar to when we see the room fogging issues, right? You can decontaminate the room, but very quickly after a new patient comes into it, it tends to become contaminated again. So I think it's important to recognize that privacy curtains are a high-touch area and that they can be one of the reservoirs for MRSA and VRE. And the other article that I think is worth looking at is Rutala's recent article as well. He probably read Oll's paper and decided that you'd have a look and see, is there a way I can provide a solution to this? And indeed did a really good study. He was looking at the ICU privacy curtains, and he found an average of 43 CFU per curtain site of MRSA or VRE, which again is a very high rate. They used a 1.4% improved hydrogen peroxide sprayed onto privacy curtains, and they found there was a 98% reduction in pathogen levels. So there are ways, and you heard Louise and Michelle talk about using wipes to wipe the leading edge, and we've actually validated that that actually will reduce the load of organisms on curtains as well. So please, one take-home thing, remember the curtains, and if you've got healthcare cleaning protocols or policies, it would be a good idea to look at including your privacy curtains in the decontamination process or cleaning that goes on. So these papers are good ones if you want to kind of review the information. Now, the other one is novel methods for environmental disinfection. This is just, there's a lot of articles coming out on this, and I think more and more we're getting data that's going to help us position it within healthcare in terms of, okay, where should we be using whole room decontamination, whether it's fogging or plasma, VHP, ozone gas, superoxide water, UV irradiation, or steam, whatever the method is. I think it's really important to recognize that regardless of which of those whole room methods are being used, you still need to have cleaning done of the environment surfaces in the patient care area, and you still need to monitor to make sure it's being done. And I'll share an anecdote. Curtis Donsky, we've been involved in a couple of committees, and he was sharing with us some local information from their facility, and he said they brought in a UV room decontamination unit, and they were using, I think they were using a combination of UV marker, and they were also using ATP because they were doing some studies to assess them. And what they found out was that the housekeeping personnel, because they saw this high-fangled, glitzy machine in the room, that they were doing all-room decontamination, they stopped cleaning the surfaces because they felt, well, they don't need us anymore. They've got this fancy machine, right? And it was really interesting. It was the UV marker and ATP readings that actually documented to them that there wasn't any cleaning being done. Now, none of these technologies are any different than our other chemical disinfectants, and the higher the organic load, the less effective they are and the longer they take to be effective. So again, I remind you that even if you incorporate some of these room decontamination methodologies in your facility, it's important if you don't have some type of system for monitoring the compliance with wiping a surface, you may not know that your housekeeping staff have decided that they're not cleaning the room because the misconception is that disinfection does it all. And that's not true. You still need to have physical cleaning irregardless of what disinfection method you're using. So a little note to keep at the back of your mind as you look at some of these novel methods. Now, the infection transmission, the environmental role, I really believe that a culture result should not dictate the practice of hospital cleaning and disinfection, because we tend to respond to the lab reports coming out saying, this person's got an MRSA, okay, put them on isolation precautions, and then especially with C. diff, we sometimes will do things differently. We'll either increase the frequency of the room disinfection or cleaning, or we'll use agents like 5,000 parts per million bleach. So I really think that if there's one take-home message for environmental cleaning, it's ensure the routine cleaning and disinfection is being well done. And I think it really is important to recognize that the highest risk of transmission to other patients is just prior to when the diagnosis is made that this individual has an ARO. So it is important to focus on routine environmental cleaning, and I think part and parcel of that is really making sure you have a monitoring system to be able to show to your staff that they are either doing the job properly or they're not, and things need to improve. So UV marker audits, Louise and Michelle have kind of gone over this, but one of the things that we find when you start doing an audit, almost invariably, most of the time you're going to find it's around 50% compliance with the sites that are marked, and with ongoing feedback, that does improve, and if you keep it up, it really does sustain the improvement of making sure those surfaces are wiped. I don't care what disinfectant agent you use, if it's not applied to the surface, you're not getting the efficacy that you're expecting from that particular chemistry. Okay, and obviously new staff training, ensure trainees meet compliance targets. We've talked about that. This one paper, there's a lot of information in the literature about ATP and environmental monitoring in healthcare. And this is actually, if you're wondering about what are the pros and cons or the goods and the bads about ATP for environmental monitoring, there's still a lot of research that needs to be done to figure out how to fit it into the system. But the PIDAC document for monitoring of housekeeping compliance recommends either the UV visible marker or ATP. So if you're considering using ATP, have a look at this article because Sciortino, basically it's the Rosetta Stone for ATP testing, and I think it's very, very informative. Okay, so I'm going to head on to the very last one, and I'm really hoping that there will be time for questions at the end of the session. So our hot chili pepper topic number 3 is obviously the CSA new guideline is out. And I want to emphasize that, again, it is worth the read because this document is quite changed from the previous version. And there's a lot of very, very valuable, I think the two Lindas referred to the fact that there's a lot of valuable charts and guidance in there, and there truly is. So I just wanted to touch on a few of those. By no means this is an extensive evaluation of that particular guidance, but I did want to raise awareness about a couple of items. Now, the concept of the A sub not zero drives us all insane, and the ISO documents all have that concept in them, and for Canada and the United States, it's been nothing but a nightmare. What the heck is an A sub not zero, and what idiot, it was a microbiologist, came up with this concept of an A sub not zero. That is now covered in the CSA document, and I'm going to show you an example of the page because it gives you some very practical examples. And in a nutshell, the A sub not zero is just trying to utilize the idea that at very high temperatures, there's a linear relationship between spore killing and heat and time. And when you get to lower temperatures, there's still, thermal disinfection temperatures, but the A sub not zero just looks at, okay, what's the net effect of the killing of organisms over the time frame based on the temperature that's being used. And that's really all the A sub not zero is. It's not at the high temperatures that steam sterilization is at, because at those temperatures there's linear relationships. At the lower temperatures, like if you think about your pasteurizers, your washer disinfectors that are used for respiratory equipment, if you look in those manuals, almost all of them now will refer to an A sub not zero value, and it's good to have some idea of what it is that you should expect from your manufacturers. So do have a look, because I think there's some good things in there, and I'm going to show you a table in a second. And the other one is endoscopes. There's a new section on endoscope reprocessing and timely reprocessing guidance. There's a really great chart in there that actually talks about, because I get asked this question all the time, okay, if I put my endoscope, I've cleaned it and I put it into the AER, but it's the end of the shift, or it's 1 o'clock in the morning, we call somebody in, they put it in the machine, and they left, how long can it sit and still be okay to use? Those types of things. Or how long is it before I need to get it into the AER after I've done the manual cleaning? Now, there is no scientific data on a lot of those, but what we did at the CSA committee was look at trying to get some expert consensus, and it's been clearly identified what is a consensus suggestion and which ones actually are based on data that's been published. And the staff, the issue of ongoing competency assessment. The other thing that's introduced in this document is the idea of monitoring of device cleaning, in particular flexible endoscopes. There's no recommendation there to say you should be doing this and you should be doing it with this frequency, but it introduces the idea that the only way you're going to know that you've adequately cleaned the inner channels of a flexible endoscope is if you're doing some form of monitoring. And that's particularly relevant if you've had an emergency procedure at 3 a.m. in the morning and that scope doesn't get reprocessed and doesn't even get cleaned until the following morning. Those are the ones that are really high risk, and in my opinion, those are the ones that we should be looking at implementing monitoring to make sure that they've been adequately cleaned. And then the other is the monitoring of automated washers. I don't know about you, but 10 years ago, nobody was monitoring their washers. So as long as the water ran, the lights came on, and you could hear noise, those washer disinfectors were used until they virtually died. They may not have been doing anything in terms of washing stuff off of the instruments, but the water came in, the lights went on, and it ran a cycle. So now the recommendations in the American guidelines and also the Canadian guidelines are minimally once a week, your automated washer disinfectors should be monitored to make sure the cleaning is actually being done properly. It's mind-boggling to me that we have so much monitoring being done for sterilization modalities, but we virtually have nothing being done to assess the cleaning. And it used to be not even the washers were assessed, and now at least we do have some of that. So looking at now this table, I'm only showing it as an example to indicate to you, this is a copy of a page from the CSA guideline, and the examples that are given are an A sub naught 0 of 60, an A sub naught 0 of 600, and 600. And there's examples of the time frames, so 1 minute at 80 degrees gives you an A sub naught 0 of 60. And you can think about that. That is the thermal disinfection parameters that are in your washer disinfectors. And that's what's making, for instance, your instruments safe to handle after they've gone through the washer disinfector. If you look at an A sub naught 0 of 600, this is 10 minutes at 80 degrees. This is the type of A sub naught 0 you need for either your pasteurizers, or if you're using an automated washer for respiratory equipment and you want to achieve at least equivalent to a pasteurizer, that's the type of A sub naught 0 that you need to get. And the way you get it, you can do 10 minutes at 80 degrees, you could do 1 minute at 90 degrees. So you can see the A sub naught 0 is just telling you at a lower temperature you can get the same killing effect that you can get at a higher temperature, providing at the lower temperature you extend the time of exposure. So it's the cumulative heat effect that is killing microorganisms. But have a look, because I know it's a very confusing concept, and the CSA guideline actually does, in my opinion, a pretty good job of helping to explain it and give practical examples. And the other one, this is just one page again. This is the endoscope reprocessing section. And what we did was break it down from bedside pre-cleaning. What are the time restrictions? What are the issues around that? And what are the remedial actions you can take if those time frames actually have been exceeded? And I think it's a very practical guideline to helping users know what to do in those circumstances. So it's broken down to bedside pre-cleaning, transit to the reprocessing room, and this is just one page. It goes on for, I think, a couple more pages. But it talks about all the stages in endoscope reprocessing and explains exactly why these timeframes are important and what approaches you can take to try and rectify the situation if it hasn't been met. And you'll notice that in some of them, it will also indicate that at that stage, if there's been an excessive time, that might be the stage at which you want to do monitoring of the cleaning. So it's actually very practical and I think a very useful guide. So, hot topic overload. I'm impressed that everybody, most of the eyes are open that I can see. There's light in my eyes, so I can't see right to the back where Louise and Michelle are, so I hope they're still awake as well. But lost, confused, perplexed, bewildered, there's a lot of hot topics out there. I've tried to share with you a few of them that I think are important and ones that may come to haunt us in Canada. And the take-home messages from my session today really are, for medical device infection transmission, we're starting now to see bacterial transmission in both endoscopes that have biofilm buildup in them and also medical devices that are getting steam sterilized. And so I think the idea of cleaning is really very, very important, and the appropriateness of storage, endoscopes in particular, dry storage. Environmental services. Certainly, privacy curtains are a high-touch area, and that monitoring of cleaning compliance. I think it's I'm going to be controversial or whatever, and I haven't had any wine, so I can't blame it on that, but I think it's a travesty because our housekeeping personnel are the front line against hospital-acquired infections, and if you don't have a monitoring system in place, you really don't know that they're actually doing the job they need to do, and that is leading, I believe, to a lack of restriction of hospital-acquired infections. And then the final take-home message is, if you haven't got it, get it, because the CSA Guideline is an excellent document. So on that note, I'm going to stop, and there's a list of references there. And thank you for staying awake right to the end of the day.
Hi, Michelle. Thanks for your talk again, as usual. Channel check. So with regards to the channel check, I've read your literature, and we were toying with how to implement a process for that, for the use of that. We do have a process where all endoscopes have to begin their terminal reprocessing within 30 minutes, an hour. Sometimes it may get to an hour. But if there's ever an issue or a breach or a possible breach or a lapse, we've recommended that a channel check be performed. And we were toying with how to implement a process, weekly, daily. So do you have any other discussion or thoughts on that process?
Yeah, I mean, everything we talk about in terms of implementing a monitoring system costs money, and I'm a firm believer, don't do something unless there's a value for what you're doing. So the two methods that are at least commercially available for monitoring endoscope reprocessing are organic residual detection, which is the channel check that was being mentioned, and ATP has also been validated for it. Regardless of what methodology you're looking at, I think the most important thing initially is to establish what's the baseline in your facility for that. And I see its primary purpose, I think, in my opinion, is as a competency assessment tool. So new staff, to be honest with you, it's a very good tool to learn or to use in training. So the individuals will clean they get shown, and then they have to do it. And if you're using something like any of those monitoring methods, it's a very good way to give immediate feedback to that staff person as to whether they really have done everything properly in terms of their manual cleaning. So I think implementation, my suggestion is if people are implementing monitoring, that they do it one kind of step, one baby step at a time, and probably one of the first places to implement it would be during the training and competency assessment, because I think as an educational tool, it's very, very valuable. I also do think it's useful, at least at the beginning, to do a one-time assessment of all your scope, or not all your scope, all your staff in terms of their cleaning competency of scopes, because it'll give them that feedback. Subsequent to that, I think the institution needs to look at, like if you had no problems, let's say you evaluated it and all the cleaning that was done that day when you took samples was tickety-boo, then I think it's up to you, maybe as a quality process monitor, to implement it in a time frame that you think is useful as a quality system check. But for sure, for those scopes that are after-hours emergency procedures that don't get processed, they're the ones where it often does require more cleaning, and you have no way of knowing how much extra cleaning to do or what to do without monitoring. So my suggestion is one step at a time, and just as the base step is checking to see what your current status is, because it's an internal tool to help you get the staff to know whether they're doing a good job or not. Yes?
Hey, Michelle. Very interesting, your first hot topic. It seems to be what I've been doing lately with MERS. And one of the things that I sort of saw from what you were talking about was the idea that, it was there, now it's here. The combat study is going to definitely show us the extent of travelers, and France has already shown us that it could be upwards of 87 to 90% of people who are actually doing traveling, who are coming. I think this also brings up the concept of using medical history as a prevention mechanism. Yeah. And so if you have someone who's been traveling for the previous 6 months, that's definitely something you should be looking at as being a risk factor. The other thing, and you brought up the microbiome, and thank you for that. Lactobacillus acidophilus and a whole bunch of others have the antibacterial peptides that actually kill the E. colis, including the CREs, and the K pneumonias and everything like that. So if you actually have someone who is undergoing the sort of dysbiosis, then you have an opportunity, and that actually answers the question that you were wondering about why you have that massive explosion. It actually is due to the lack of the lactobacillus. So if you also have a patient who's undergoing any type of intestinal or dysbiosis inflammatory problems, then you should be definitely concerned about having AMR, ESBL, and of course CRE. So I just wanted to add that to the public here to let them know that not only are you on the right track, but you're actually just at the tip of the iceberg, and where we're going in the microbiome and also medical travel histories is actually to give you the influence to be able to prevent by simply asking a few questions.
Thank you for adding that. I think those are all very, very valid points. And we all know that when our gut works properly, things go great. But you also know that when you travel and you start getting diarrhea, the Imodium commercial, I think, is a good one. The idea that the dysbiosis of the gut causes significant problems. And if you have antibiotic-resistant organisms that are the last bug standing, that just makes you even more susceptible. So thank you for those comments. And I think we're going to see a lot more on the microbiome issues in health as time goes on. Yes?
Just with the ATP audits and the fluorescent audits for environmental services, fully support monitoring that to ensure it's a good quality assurance process. What we're finding in our organization, though, are the staff. They're just wondering about the sensitivities around staff for that, because our environmental services staff are feeling like they're under the microscope. They're being scrutinized very carefully, and other healthcare providers like nurses aren't being watched as closely to see if they're doing their practices appropriately. And just wondering if you have any tips on how we can help them buy in better and not feel so victimized.
I think that's such a good point that you're making. And Louise and Michelle at the back, certainly we've encountered that. We did a survey of the housekeeping staff at the St. Boniface site, and it was sad to me to realize the staff, the housekeeping staff, felt more valued by the patients in the hospital than they did by their other hospital staff, the nurses, the doctors. And that's a sad statement, and it alludes to exactly what you're saying. What we've tried to do, and we're trying to find better ways to do this, is to make them recognize, or the housekeeping staff to understand, they really are the front line in preventing transmission of hospital-acquired infections, because the environment is a reservoir. I don't think, you notice none of us talked about, is it a reservoir? It is a reservoir, and we need to find ways to ensure that the disinfection of those high-touch areas is done properly. And one of the things that is really hard to empower the housekeeping staff with is when they go into a patient room and there's family there, or the patient's in the bed, like what level of cleaning. And we were tossing around the idea of actually having buttons made for them and say, ask me how I help prevent infections on the housekeeping staff. Because what we've tried to do is, this isn't a punitive tool. This tool is one to show that they are doing a great job, and it is a hard trek to actually get the housekeeping staff to really buy into that. But I think Michelle and Louise can attest to the fact that the housekeeping staff, they've been using it for years and years and years, and after a while they do get used to the fact, and we used to put the charts up on the ward so that the patients would know too that we're doing a good job with the disinfection of the healthcare environment. So I think the idea of presenting it to them where you're basically publicizing they're doing a good job, and that if there's transmission of infections, it's not because they're not doing their job to break the environmental component of the cycle. And the other one is to empower them and recognize them as germ busters. I mean, really, they are the front line, and if they're not doing their job properly, they need to know, and they won't know unless you're doing monitoring. So, good point you're making. They do feel like they're under the microscope. Michelle, I don't know if you want to add anything more to that. Like, you have frontline, face to face with your staff every day. What would you say?
I wouldn't say that they necessarily feel they're under the microscope anymore through our department, because they due to education, they do realize that what they are doing is they are doing the frontline part of germ busting, as you said. We do post our results in our department, so our staff are able to see them. We do post it, just so you know, by blocks, not necessarily by floors, because there are some floors that only one person works, so the union has asked us not to do that. But I find our staff ask us when they don't have results in the last little while. They actually come up to us and say, when was my last inspection? I haven't had results recently. So they're actually advocating for it now. So yeah, we don't really, like, we did struggle at the beginning, yes. I mean, it took us a long time to slowly introduce what we were doing. It took us at least 6 months at the very beginning to slowly introduce the premise of what we were doing and why we were doing it. It was not to get you into trouble, but now they actually advocate for it.
And I think the one other thing that is also very helpful is we don't talk much about our housekeeping in all of our hospital newsletters. So another place to put it is if you are doing monitoring, celebrate the successes. Like if you've got over 80% in certain wards, you know, that's a good thing to put in your hospital newsletters to celebrate the environmental services in terms of the good job that they are doing. I know whenever I see housekeeping staff in the cafeteria and I'm down there and they're cleaning the table, I actually stop and talk to them and say, you know, I'm so happy you're doing this because it's so great to see. And you know what? They're happy when you actually you know, discuss them about the value of what they're doing, and that's just in the cafeteria. So I'll stop there and yes, go ahead.
Hi, Dr. Alfa. Thanks for the session. You mentioned about monitoring the washer disinfectors. I was wondering, do you have any recommendations for checking the efficiency or efficacy of the cleaning and disinfection for bedpans and urine bottles? Would you recommend like ATP water, etc.?
Well, it depends on how you're reprocessing it. If you're, because the question is, are you going to monitor the automated washer or are you going to monitor the actual device to see whether it's clean when it comes out? And those are two different issues, right? Right now, I think it's even a big step to get healthcare facilities to be monitoring the washers, putting monitors inside to make sure that the cleaning efficacy is correct. And I know exactly what you're getting at because Louise Bulow-Smith at the back is my partner in crime when we had ward bedpan washers and there was, you know, urinal bottles and other things being put in them. And what we found was even using one of the easiest to clean cleaning monitors, the Tosai device, and please, if I mention company names, it's not because I'm trying to promote anything, it's just that was what was used. And Louise came to my office and she said, and there was virtually no removal. And she said, do you think there's, you know, this is a problem, right? And I said, yeah, because I know this monitor is so easy to clean off that if the ward bedpan washer isn't doing the job, and that's how we got into looking at ward bedpans. And the reality is the bedpans, because of their design, unless the unit, the washer, is actually getting fluid into the right nooks and crannies, it's not going to be able to do a good job of them. So monitoring them, I don't have an easy answer for you because right now I think it's impressive if sites are actually monitoring their washers to make sure they're doing a good job. But the problematic things like bedpans, Louise is standing up, so maybe she wants to give a comment. Or is she trying to escape?
It's a really near and dear topic, and one of my other hats is in New York. And with different washers, there are different cassettes or trays, storage devices that can be purchased, and not each company provides the same. And also for basic patient care items, which are considered lowly in terms of the fact that they don't go through sterilization, but certainly can be linked with hospital-acquired infections. There is no manufacturer's inspections. So what we do, because we have a choice of racks and a choice of washers, is a made-in-MDR Marine at St. B solution, which is to take a Tosai strip and remove the plastic lid, because the plastic lid is to emulate a hinge device. And this isn't a hinge device. So we take that strip and we put it in what we perceive as difficult to clean locations on that device. And then we will put them through different washing options. So sometimes that might be on a cart washer, sometimes that may be in a specialized loading carriage for an instrument washer. Whichever process gives us the best result, and it has to actually be a good result, is the one that will win and be the one that we go forward with. I can tell you that if you use cart washers for bedpans, certain design of bedpans, and you put them on, they're long orange carts, and you put them like this, and the washer's coming like this, and you think, oh yeah, I can tell you under the lip, you're not getting anything. So so we have the ability to test our washers, and next step is going to be how do we ensure that what we're placing in those washers is actually being placed in such a way that the cleaning can work.
Thank you very much for that, Louise. That's very helpful. And Linda?
Michelle, great talk. Just so enjoyed it. It was
Thanks.
wonderful. What I was thinking about is when they were talking about being under the microscope and monitoring and different things like that. When I think of MDRs and medical device reprocessing, we do have a competency checklist, and that. What I've encouraged staff, if I give a competency checklist, is they get a copy, I keep a copy. So throughout the months or year before, if they find that they're having difficulty with an orthopedic set or with an endoscope or type thing, they identify it themselves and say, listen, I'm struggling with this, or this new device come in and I totally missed the in-service. So that puts the responsibility back on us, and it also, the staff hold the responsibility that they need to inform us when they feel that they're having difficulties. So those competency checks are wonderful, and they can work two ways. The staff can own them, and the supervisor, because many times it's hard to get those competencies done. And if the staff are self-identifying, I think it's the best way to go.
I think you're absolutely correct. And the staff at the front line actually are the ones that can easily identify what are the problematic instruments, and maybe getting some additional training on that actually would be very helpful.
I just had a really quick follow-up question. Is it true the biofilms will impact the RLUs for the ATP tests?
In what context are you talking about? Is your question, can the ATP test pick up biofilm?
No, would it reduce the levels that you're seeing if you're having biofilms come?
I don't think there's enough data that's been published in terms of biofilm, traditional biofilm, in terms of how well ATP picks it up, because there's two places where that's relevant. One is in the environment, and I'm not talking about that, but the reality is that there's not a correlation between, if you do culture of your environment and you do an ATP test, you often will find that there is no correlation. You can have 0 bugs on that same spot, and yet you'll get high RLU values from it, and it probably has to do with the organic material that is present, because we have, ATP is not, those rapid tests are not a measure of viable bioburden. They're a measure of the cleaning that's happened, and there's far more ATP in the organic residuals that are in the environment, and dead bugs, the ATP in them, whether it's dead bugs or dead eukaryotic cells, they all have ATP, and ATP is very stable when it's dried in the environment. Was there a comment at the back?
Yeah, I did that testing with 3M back in the early 2000s back at the University of Ottawa. We had no correlation. My brain fried for 6 months, and we could not find one. John Boyce took over. He did the cherry picking of the data to put out that JHI paper. There's been no correlation, and other than, I don't think Barley's here, but there's a few people who still believe that there is, but it's absolutely nothing to do with actual bacteria, biofilms or anything. It's just a measure of cleanliness. Yeah. But of course, if it's not clean, then there's a very good likelihood you're going to have bugs there. But
that's right.
Don't make that link, because it's
no.
not there.
And that's a misconception that many of the public have, that ATP is actually measuring viable organisms, and it's not. There's been more than enough data in the literature. It is a surrogate measure of the cleaning that's actually been done on the surface. So I would agree 100%. In terms of biofilm, though, like if you have biofilm inside an endoscope channel, will you pick it up, or will it mask the ATP results? I don't think we have any data that actually will help direct us one way or the other on that. So I can't really answer your question. If there's organisms there, in a high enough level, and I'm talking 1 RLU requires about 3 logs of a gram-positive organism. So it's very insensitive, and definitely even with high levels of organisms, they have to be very, very high to register as RLUs that are out of whack. Louise, you get the last word.
Hope this is a quick question. If it's not, just tell me to go back to the back.
You didn't throw peanuts at me. I won't tell you to go at the back.
I'm intrigued with the design of the arthroscopic shaver handpiece, because that design repeats itself in an alarming number of instruments. And it brings up something that I've just recently faced, and that's the design of cystoscope sheaths. And our requirement that, and it's
it's a made-up word, but I use it a lot, disassemblable. So we want our stopcocks to be disassemblable. And so in looking at the design there, because it's a T-shape, which is a challenge, and there's some other things going on, but it also has stopcocks. But when we're reviewing equipment for the IFUs and our compatibility with existing processes like we're supposed to do, we are consistently running up with a challenge with our European counterparts in terms of how they are viewing the total effectiveness of steam sterilization to override all eagles and some of the things that we're seeing with design. So I'm just wondering if you can comment a little bit on how is North America, or how are some of our challenges that we're seeing here, and what the Europeans are seeing, and are we looking at maybe a little bit of a different approach, or perhaps a consistent approach between the two continents?
Well, I think you're right in terms of the design. It's like the Yankor suctions. I mean, to be honest with you, I think those were developed in the 1800s, and the design has never changed since then, and they're designed to produce failure because you can't get the fluid flow through them in a proper manner to actually properly clean the inside of them. The arthroscopic handpieces and the trocars for introducing it, I think, is a little different, and those stopcocks, I would agree with you completely. I think that what we need to have is better ways to actually get adequate fluid flow, because even the brushing, you saw, there's even examples of bristles that fell off in the middle of the handpiece when they tried to use brushes. There needs to be some design considerations, I think, to improve the cleanability if it's a reusable device. Now, in terms of the difference between Europe and North America, it is day and night. I mean, to be honest, they're far more proactive about their water quality. They are as fixed, I think, to the idea of parametric release. The idea being that if you put it in a steam sterilizer, and as long as the arrangement of the packages is consistently the same in a load, they don't use BIs and CIs in the way that we do in North America. But I do think that it all gets back to the cleaning. And I would have to say, I think the Europeans are probably far ahead of us in terms of having a monitoring process for the cleaning component, because it is part of the quality process. And so I think we're kind of playing catch up in terms of the cleaning aspect of it. And we're all struggling with it because most of the quality process was destined to the sterilization and disinfection process, and we've kind of got monitoring being done there, but virtually no monitoring being done for the cleaning. So I think the parametric release is a whole other ballpark, right? Because I think whether you use parametric release or whether you use your BIs and your CIs to actually release your loads as we do in North America, the reality is if you get a chunk of tissue inside a shaft of one of those devices, eventually you're going to have problems with it because even steam may not be able to kill the organisms that are inside the tissue and may be protected from the steam penetration. I don't know if I answered your question, but I'm tired, and on that note, we'll leave.
Thank you very much, Michelle. That was excellent. As an ICP, I wanted just to say that I was extremely pleased with the speakers that we had today, and I really want to thank them for coming here and giving us all this information. I think it's wonderful. But I also wanted to thank Virox for all the work that they do in supporting our conferences, and they're the ones that got these great speakers. So how about we give Virox a hand? Thank you.
Darlene took the words out of my mouth. I certainly was thrilled with all the presentations that everybody did, and thank you so much to everyone for the time that I know it takes to put a presentation together, and changing back and forth in discussions, even if you were able to drink some wine or eat some pie while we were having our conversations, Linda's. So our next symposium will be in 2016. That just seems so far away. As I said, please fill out your evaluation forms for today, and if you have any ideas for topics that you'd like to look at, please let me know either through that or email me directly, because I basically give myself maybe 4 months of a break, and then I start actually looking for speakers, because some people I need to book well over 12 months in advance to make certain that they're going to be here today. So thank you for sticking around. Just a reminder that the opening ceremonies is at 6 o'clock. I have no idea what room it's in, but I know that it's at 6 o'clock. And then followed by that will be the exhibitor hall, and I hope to see you there as well. Thank you.